screening to identify individual risk. My name is Baden from WorkSafe Tasmania, and I'll be your moderator today. Today's session is presented by Dr. Mary Wyatt from the Tasmanian Association of Rehabilitation Providers. In recognition of the deep history and culture of this land, we acknowledge the Tasmanian Aboriginal people, the original and continuing custodians of the land, sea and sky. We acknowledge and pay respects to all Tasmanian Aboriginal people, all of whom have survived invasion and dispossession and continue to maintain their identity, culture and Aboriginal rights. Please now take a moment to read the following slide about the information received today. Please use the chat tab to type any questions you have for today's presenter. These questions will be answered at the end of the webinar. Only presenters' webcams will be used, and today's presentation is also being recorded and will be available on WorkSafe Tasmania's YouTube channel at the end of the month. It is now my pleasure to introduce your presenter, Dr. Mary Wyatt from Tasmanian Association of Rehabilitation Providers. Mary is an occupational physician with decades of experience in injury management, policy and research. She has led early intervention programs, advised governments and employers on return to work practices, and founded rtwmatters.org to share evidence-based approaches. Mary is a lead fellow of AFOEM/RSCGP, helping to drive policy initiatives such as It Pays to Care, which promotes evidence-informed work injury schemes. My pleasure now to introduce Mary and throw to her presentation.
Thanks so much, Brendan, and thanks to TARVP, the Tasmanian Rehab Professionals. So I'm not actually from them, but they've coordinated today. We've done a few things together, and they're a wonderful organisation. So I'm pleased that they've coordinated today. It Pays to Care, I'm going to give you a few slides. It Pays to Care is policy from the College of Physicians, and we've been advocating for it since April of 2022. It looks at an overarching view of how schemes operate, but I guess what I'm here to talk today about is what underpins the policy, and that is the biopsychosocial framework. So we've known for decades that psychosocial issues are important problems in return to work, and they are significant barriers. But I've been kind of like many other people of my vintage, have been around for a while, and have watched the whole kind of psychosocial discussion, the flags, the yellow flags, red flags, blue flags, model over decades. And it's kind of a response is a bit of a mere response. What do we do about it? And I guess one of the reasons we've developed It Pays to Care is the evidence has substantially increased over the last 10 years. And my aim today is to introduce you to the topic, get you familiar with it. I think it takes a few years to fully grasp the breadth of it, but there are bits you can pick up. This can be really practical at a case level, at a workplace level, and at a scheme level. So you can come and think of this in different ways. Please type questions into the chat or the question box at any stage during today's presentation, and we'll talk about those at the end. And questions are really valuable because I've been working on this for 4 years now, and so I'm kind of, you don't know what you don't know. So if you've got a question, others will have the same question, so please ask. So let's start with some data. On the left-hand side, psychosocial factors account for up to 85% of prolonged work disability. That is like a big issue, and we've kind of known about it, but haven't known what to do with it. Here's another important piece of data. This is data from New South Wales, and what it's telling you is that when we measure psychosocial risk, those classified as elevated risk have 3 times the amount of time off work than those who are in the low risk group. And how do we classify these people? Well, we classify them by a psychosocial screening tool, the short form Örebro. There are a range of tools you can use. This has been the most widely studied around the world and probably the most valuable. So it's been used by physios around Australia for decades, but we haven't really been putting what we've learned into practice or what we find from the screening into practice. So another way of describing this is for every one, the short form of Örebro is a screening questionnaire out of 100. And 50, we've defined 50 as the cutoff, but really it's not a black and white. It's a dose-response relationship. So if you have for every 1 point increase in your risk score out of 100, the likelihood of people being back at work when the study was finished was down by 4%. So that's massive. Every 1 point increase for return to work was down by 4%. Huge evidence that this is a predictive tool. We've looked for predictive tools for a long period of time, for decades, and this is seems to be effective. So there we go. So in our current system, we don't deal with these issues. So in our medical sphere, and I can talk about this as a doctor, we are very biomedical. The issue for biopsychosocial, managing people in a biopsychosocial framework is it takes time. It takes time to listen to people and to talk to people and bring out the nuances. And medicine is time is money. And so it's hard to get enough time to actually address psychosocial barriers. And certainly in medical practice, we don't go near it. We barely touch it. I know in general practice where I was in the 90s, I tried to have a few conversations with people about what was going on in their mind affecting what was happening. And I just failed so miserably. And I could see them walking out the door singing, the doctor saying, you know, it's all in my head. How you deal with people and how you frame things when we talk about psychosocial barriers is really important. And we're lousy at it as doctors. Many health professionals are. I think some others are better. But I think as you specialise, we even get worse and worse at it. Pain management used to be the purview of addressing psychosocial barriers, and it's now become, at least in Victoria where I'm based, a very interventionist approach. So that's unfortunate. I can just see some people are having trouble hearing. I'm terribly sorry about that. This is the same applies for physical and psychological claims. And there's some data here, you know, GPs and physios identified 5% of barriers, whereas a screening tool identified a lot more. We don't ask the questions in the right way when we use a screening tool. We're giving people privacy. They do it in their own, not being biased by our views and how we approach it. So some more data, that's a replication of the previous slide, but on the right-hand side, on the chart on the left, but the chart on the right is basically telling you for every extra barrier, for every extra psychosocial barrier, then there is a reduced chance of a person being back at work at 1 year. And so that's massive. Now, a key thing to tell you, and I believe these slides will also be shared with you because there's links in there to resources. So the first piece of data I want to show you is about the results of the intervention that addressed these psychosocial barriers. So this was the first intervention, and this was started kind of about 10 years ago. And this was public hospitals in New South Wales. So the blue, this is looking at claims costs by month. And what you can see in the blue chart, the blue area, is the control hospitals. And in the red area, you can see what happened to people in the high-risk group in the intervention hospitals. And immediately you can see there's some increased claims cost to start. And you'll realise why when I talk about what the model was. And then after that, look at the reduction in claims costs. So at 30 months in the intervention group, no ongoing claims costs, but look at this group. So 30% reduction when the study was finished in claims costs. 50% reduction in lost time, massive benefit, massive benefit. Now, what it is basically a system of this intervention involved, for those at elevated risk, it involved giving them extra giving them extra support at the workplace, extra healthcare support, and psychosocial counselling. Psychosocial counselling is not just going to a psychologist and having counselling. It's very targeted at the here and now and how can I deal with this problem. Wasn't it good I got the water, Brendan? So they were allowed up to 6 visits with a psychologist who'd had psychosocial counselling. These were psychologists near the hospitals. And the average was 5. So you could see that, there's quite a few who are getting under the needed 6. The extra workplace support was from the return to work coordinator, injury manager. And they basically would visit them and check on them and give them a bit of extra support. They would try and address any workplace issues that were flagged. There was extra healthcare support. So in New South Wales, where this was done, they had the option of sending patients to a injury management consultation, which is kind of halfway between a treating doctor and an IME. And that person would focus on the return to work and they would speak to the treating GP where they could. And that's not always possible because you know what, GPs are not always easy to contact, even as doctors. But look at this model. And so the reduction is just massive. Now, this has subsequently been replicated at Australia Post, and a range of other organisations have been implementing it. There's a range of other evidence. Some of it's published, some of it's not. But that evidence is consistent. If you get in early and do that counselling, you have a major impact on mental health. So if we want to reduce secondary mental injury, this is the best intervention I have seen. And we know that if we have a physical problem, return to work might be like that. If we have a mental health problem, return to work might be like that. Well, if you have a mental and physical health problem, return to work is down here. I hope I'm making sense. But a combined physical, mental ill health condition has the worst outcomes. And so preventing that is just so important for the person themselves, but also for the whole scheme in improving outcomes. And I guess the other thing to say is the job satisfaction from this model of care is fantastic for those involved, whether it's the insurance case manager or the injury manager. If you've got less distressed people, and that's what you're doing, life is easier in all spheres. So let's talk in more depth about the approach. There's 3 steps, not the 3 intervention parts of the WISE model. There are 3 steps, 3 key steps for this system of work. And there's lots of different ways you can put them together and implement them. So the 3 key steps, the first is you've got to identify that, you've got to screen to identify risk. You've got to then assess the person's risk, what is going on. And then the third is matching care to the risk, to the particular issue. So if we think of a more everyday example,
Hang on, Mary. Excuse me, Mary. I think we've lost your audio after that internet glitch. We might just wait a moment and see if we can get her speakers back online. We might just have to wait a moment. Mary looks like she's attempting to get her headphones back online. No speakers. We may have to pause this session and while Mary reboots her computer, and we might just come back. I think the room should be ready to stay in place if we need to go that way. Yep. So apologies, we're having some technical difficulties with our presenter. We'll reconvene in a moment. We'll give her a chance to log out and come back in. Might be a good time just to think of any questions you might have already, and also I'll speak the rest of WorkSafe Month. So as you would be aware, we are providing around 60 in-person and webinar sessions this WorkSafe Month. So a reminder to go and make sure you're booked in. No, Mary, we're still having difficulties with your microphone. And thanks to Tracy, who's just popped the web link for the rest of our program in the chat. One of the chat members is asking whether you've accidentally muted yourself, Mary, but I can't see the mute icon, so I reckon it might be a system level thing.
Is that any better?
Woohoo! Thank you, Mary. We're back online. Thanks everyone for your patience with that slight bit of computer fun. It wouldn't be a Monday without a bit of IT.
Adventures in system settings. Anyway, thank you for everyone for your patience. I think hopefully I'll know where to go next time. So there are 3 steps. I think I've mentioned them. So the screening, I remember where I was at. So I go for mammograms. I'm over 40, hard to believe, I know, 45, 50, whatever it is. So if I have an abnormal mammogram, nobody's going to chop off my boob because I have an abnormal mammogram. They're going to go and find out what the issue is. Okay, so if we think risk rating with a psychosocial screening questionnaire or a deep conversation with the person to identify barriers, so you want to screen, you want to identify those at risk. And what you're really looking for is distress. Yep. That's what the tool is measuring. So when you're doing a screening, you want to do it as early as you can. In the WISE study, it was done within the first week. It can be done in multiple ways. You can do it over the phone, which is what it did in the WISE study. You can, in WorkCover Queensland, they send out an electronic link to the short form Örebro. People fill it out on their phone or their computer, and then it integrates the data, the results and the individual results in the WorkCover Queensland system. So that's a high sophisticated level, but a hard copy form is there. Lots of different ways you can do it. You want to set it up in the right way. You want to tell people that you're asking these questions because you want to understand how they're going and what you can do to support them. You want the system, you want the answer to, so the result of the screening questionnaire to tell you how you can progress and what to do. So you can either deal with, so you might do your short form Örebro. Let's just say you get the score of 65, which is a not uncommon level. So then what you want to do is you want to delve into what are the particular issues that's causing this person to have an elevated score. And we'll go into more detail about how you can do that. But a generic approach of giving everyone support doesn't work. You've really got to target it. And that makes perfect sense, of course. Once you've gone through and identified what the particular issues are, then it's a matter of addressing them. And psychosocial counselling is really great at doing that. You know, we all get stuck in our lives. We talk about psychosocial stuff, but it's not like psychosocial stuff happens to people who've had a claim only. We've all got psychosocial barriers. We've all got things that affect us in our lives. So our thoughts and beliefs have are real and have a tangible impact on what happens to us. And that is from the Yoga Sutras from 2,000 or 3,000 BC translated. So that's just part of human nature. So we ignore that at our peril. And often these barriers are just things in our head that are not that difficult to overcome. We might get a bit stuck on them, or they're things that would be a difficulty for anyone, and helping, supporting people with that creates something. It creates, you're there to help them. And when you're there to help them, reciprocity, this part of human nature, one of the most strongly correlated facets of human nature across societies and through history, you respond in kind. If people are helping you, you are way more likely to be helpful back. If you feel you're a number and not being heard, you know how we're going to respond. I know how I'm going to respond in those circumstances. Clam up, be uncooperative, be more difficult, etc. So when people get you out to help them, it changes the dynamics. We're so focused on the here and now and the transactional, we need to upgrade the certificate or change their duties, but it's the underpinning that makes the big difference. So match what's needed. Is it an issue at the workplace and you want to get the injury manager involved with switching some things or modifying or having some conversations at the workplace to improve things? Is it the person's financially struggling and they need some basic financial advice and they can be referred somewhere? Is it they generally have some struggles with coping, whether it's a teenager on drugs, like, I mean, we'll all have trouble with that. But, you know, if they have generally passive coping style in the face of problems. So it's not a complicated system, but you need to stick to it. It's what we've seen at a scheme level is sometimes one is done without a system to implement 2 and 3. And so there's a lot of energy going on to identifying people with barriers, but then not having the systems in place to deal with them. So, and then I've seen other systems which are kind of 2 and 3, and actually they're pretty good, but they're way later than they could be. So you don't have the screening good in place. So you've got to have each part of it, but then you can do it in multiple different ways. So going into more detail with screening, what you want to do is capture as many people as possible with screening. That's why we have, you know, screening mammograms for everyone over a certain age, or they're sending out bowel tests for, you know, test any blood in your poo for bowel cancer. We want to make screening as widely available as possible because we want to pick up all those important people. I've seen figures quoted of 10 to 12 return on investment times return on investment with this approach. So you don't want to leave people out. It's more expensive and poorer outcomes for you if you don't capture all those people. Fire Rescue New South Wales has been doing this for over a decade, and they do it on steroids. So they, with any firey that's off work for more than a few months, they're doing it. They have a cutoff 48 rather than 50 because they want to capture as many people as possible. And then they repeat it every 3 months for anyone who's off work to make sure they're capturing that psychosocial risk. So early plus any time, do it in the first week if you can, but repeat it. If things go off the rails all the time. More typically, you see problems from the beginning, but sometimes things will go smoothly for a month and then things go off the rails. So feel free to repeat it. You don't have to just stick with, everything was fine first time round. Things change, so feel fine to repeat. As I mentioned, you want it to be sensitive, to not miss people. You want any screening questionnaire to have as few questions as possible. So QBE have been one of the early adopters of this as a private insurer, and they have an online, I'm not sure if it's across all of their jurisdictions, but they have an online screening tool. It's 4 questions. Now, they can ask 4 questions because they know their data. They've been doing machine learning and watching their data for years. So they're very familiar with it. They can understand the ins and outs, and they can assess this tool that they're using. And so at claims lodgement, they have an animation that people click on and answer questions. And that is another easy way of doing it. So as few questions as possible. They're down to 4. We're still at 10. The questions need to be clear. You tell them that, just do the best you can. There's no one right answer. You explain why, to help me understand how I can support you. You really want to do it as business as usual, whether you're in rehab or claims management or at a workplace. This is probably a really good big workplace model. And then you want to integrate it with your other systems so that you don't want to load people or burden people. Like, you know, when you're dealing with an injury, whether it's as an injury manager or a claims manager, there's so much to do in the early stages. And if you make this a hard process to put in place, then it's going to happen much less often. So you want to put it in so it's done as business as usual and it's streamlined. If you're just dealing with individual cases, that's, you know, hardly any, that's fine. But if you're dealing with a decent number, you really want to have it integrated. And that starts with structuring it into your systems. So lots of different tools. There's the short form Örebro, as I've mentioned. It's probably the most widely studied, the most widely used, can be done in different ways. Pam Garton has a different tool, Abilita. It's 5 questions. She's got a whole system of work under the Abilita system, so screening, assessment, and then systems for coaching people to do coaching. There's a conversational tool you could use, but and there's other kinds of screening questionnaires like the Start Back tool, but I think the short form Örebro is the most widely used and the one most people are familiar with. And unless you have a good reason to choose another tool, I think that's probably the most sensible. If you are, I've seen some insurers develop new tools, it's very important to test them. If you're going to develop your own screening tool, you really want to test them. And the easiest way to do that is implement it on 50 people, 100 people, 200 people, proper study, 200 people, and see what happens to the claims cost at 12 months by the score. And that gives you a good assessment of whether the tool is predictive. It's important in any tool that they're covering all the domains: function, emotions, coping, confidence, work perceptions. And it's best to train people in how to engage people with the survey. If you say you're going to start doing this in a big workplace, you'd want to train all your injury managers in how to introduce the tool. You can choose your own risk rating. 50 is the pretty standard. Some people choose other or lower levels. This is what it looks like. I don't expect you to read it all here, but these are the sort of questions. And so give this on a scale of 0 to 10. We also, we want to know, have you been depressed in the last few days? And if so, how much? And does activity make your pain worse? You satisfied? Blah, 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 blah. It's interesting, the fear avoidance questions on here have the weakest correlation. We know fear avoidance is a really big issue in musculoskeletal medicine. That is, people worry about their back problem and they avoid activities, but it doesn't correlate as strongly with the other questions, which is just a point of interest. So that is the short form Örebro. It's got a special scoring system. You can't just add up all the scores. You've got a 10 minus in some, but that's the system. And so what you would then do is, if somebody's at elevated risk, however you determine it, say over 50, let's say 55, 65, 75, the highest score I've seen is 99, and it was on a physio treatment plan form, and it was ignored. And that whole case was a fight about treatment, and the woman was working, but she really felt she needed this treatment and was really distressed. And the argument about the treatment probably was causing the distress. Anyway, that needed to be tackled. You needed to have a conversation about that if we could weave away, you can't say yes or no in that situation. You've got to address the issues. Anyhow, so the score matters. And once you've got an elevated score, it's then appropriate to do a richer assessment of what the actual issues are. There's a lot of different things that influence it. So, as I said, fear avoidance, passive coping, emotional distress, what else is going on in the person's life? Perceived injustice is a big one. We don't talk about it enough. But these are all the sort of areas we want to explore. And so an assessment can be, I think you want to be a clinician here or be trained in it. You can do it without it, but you want to have good people skills. So an assessment really means engaging with the person, getting to understand what the issues are, and then working further. So you can do that clinically. You can talk to the person if they trust you, or you can do more questionnaires. The best approach is both, really. So in these models I've talked about with the WISE study and subsequently replicated at Australia Post, they used the DAS, they used the pain self-efficacy, the brief pain inventory, and was one other I've forgotten, but anyway, and so they used about 5 psychosocial. So people would fill those out. So that's maybe another 30 questions. You're not going to do that for unless it's really necessary. And then the psychologist would talk to the person about their responses and then tease out what their particular issues were. And having a suite of questionnaires is probably the most efficient way of getting to the key areas. Don't have to have it, but it's useful. And then really the next step is psychosocial counselling. Now, this came out before I needed to send my presentation through to Tassie, but if you Google the Open Pain Network, you will see, because a few people are saying, well, where do we find somebody who can do psychosocial counselling? There is now a nationally available psychosocial pain management coaching program. I shouldn't say coaching, teaching health practitioners how to manage chronic pain, which is really framed around biopsychosocial counselling. It's not all, but I think if you're thinking about, as a healthcare practitioner, becoming a psychosocial counsellor, then this is an option for you. It's an online course. It's $280. It's through a federal government grant. It's a whole bunch of really well-regarded people in Australia who've set this up, and there can be accreditation as well. So maybe, Brenda, we could include that link if this webinar is going out. I can send that to you. So psychologically informed intervention. So now you've got what the issues are for the individual. It's a matter of helping them work with it. So what is psychosocial counselling? It uses a range of strategies. Like if we think of an example, I'm anxious about going back to work because I've put in a stress claim and I don't know what they're going to think of me when I go back to work. Now, that would be a realistic thing for everyone at 11 o'clock at night with a mental health claim to be thinking. I would be. Most people will be. So how do we tackle that? That kind of thing, you can get stuck in your head. And if you're not good at overcoming barriers, that could really hold you back. But maybe you could have some discussions about how logical that is. Like, what have you done that people would actually be thinking that? And then how you might actually go back to work and proactively deal with that. You and your personality, because we're all going to want to deal with that differently or feel we can deal with that differently. So how can I as an individual overcome that barrier? That is the practical here and now of psychosocial counselling. So there's behaviour techniques, it's understanding pain management, so understanding how what goes on in your head affects what goes on in your body, being able to have that conversation that I could never have as a GP decades ago. And so, and then playing to people's strengths, building their resilience, working out, what are their strengths and building on those goals that are relevant to them. And so giving them homework, things to do. So it really works across the spectrum of issues, but I think I've given you that it is in the here and now and practical. So going back to the model of the WISE study, that's what they had here. Psychologists near the hospital, injury management consultations, and case manager organised early referral for the injury management consultation. But there's different ways of putting this in place. So I think I'm just going to get back to this previous slide. There's a lot of different ways of putting this in place. So, for example, Australia Post said, we have pretty good systems, we're doing pretty good, but we'd like to do better. So Melanie Anson, who ran Australia Post, went to Professor Michael Nicholas, who led the WISE study, and said, hey, can I have some of this, or can you help me put this in? And they did that then over 12 months, I can't remember how long, and they then ran that starting in 2020, and we all know what happened in 2020. So that kind of didn't actually, they thought it would make a difference, but it didn't actually make a huge degree of difference. So local psychologists in the WISE study, is not going to be a local psychologist you can train in Tennant Creek, maybe. So Australia Post all around the country, they needed a different model. They went to their EAP provider and said, can you do this? And they didn't just use the psychologists in the EAP, they had them trained. So Professor Nicholas trained the psychologists in psychosocial counselling, and they used them. There are other providers. There's the Navigator Group who's doing this at scale in private insurers and in some public insurers in pilot. There are other providers like Access, or a range of providers who can do this with you. If you have to find local people who can do it. It might be a local individual, it might be a local provider, it might be a national provider. But you need to find those psychologists. Other people have taken different approaches, but it's a matter of sourcing them yourself and finding who's going to work with you. And it has to be a system of work, so they need to work with you. So I guess I've given you key aspects of implementation. Varies a lot according to your setting. If you're working in a business of 100 people, you might be doing the screening yourself and then having that conversation and work out how you can help that person. It doesn't have to be super fancy stuff. That is better than not doing this approach at all. If you are working at scale, like a big insurer at a jurisdictional level, you've got to have your systems automated so it happens behind the scenes, and you've got to work out what is your best system and who to work with best. So one of the things that we know from a big study done by Institute for Work and Health in Canada and the Healthy Working Research Lives group in Monash, which wasn't named that at the time this study was done. I can't remember what it used to be called. But this was a massive review of lots of studies. And basically it said that if we want to get good return to work outcomes, we want to have both, we're going to have all three parties involved. So you want the health providers involved, you want the case manager involved, and you want the workplace involved. In some of these psychosocial models of care, it's just the service coordination. It's done through case management and service coordination, and there's no requirement to get a GP referral or GP sign-off. And we're still waiting to see which of these makes the difference. But that notion of the psychosocial counselling without having to get GP sign-off and engage the others is also a really worthwhile system to think about, because in New South Wales, the doctors weren't unhappy that people were having psychosocial counselling. They didn't mind. They were very happy because it was helping their patients. So that's another different model of care. Do you engage all parties or do you focus on the psychosocial counselling? I don't think we know the big picture answer to this at the moment. So in your particular roles, and I'd love if you've got any questions on this, tell us about your roles. As I've tried to say, there's a varying level of sophistication depending on how streamlined your system needs to be. You can just be basic support. You can do this without any tools like psychosocial screening questionnaires, by just meeting with a person and talking with them and listening. 20 years ago, I was part of running a major intervention, proper peer-reviewed study. We had 40% reduction in claims costs, 6% reduction in days lost. fantastic results, but it was so hard because you had to get top-level case managers to be dealing with psychosocial barriers early. And so it was just so much more difficult. That's what I love about this system. It's just simple to identify what we had to have really experienced and effective case managers to do. So it does make things quite a lot easier. So you can start with basic support. You can engage the GP if that helps, engage a local psychologist with relevant training, or you can put in a full system. I've certainly seen some rehab providers around the country who start with this as a routine psychosocial screening. Let's counsel, let's support them with psychosocial support. So if a simple learning plan, become familiar with the short form Örebro, try it out on people, try it out on a friend or two if you want to first, and then try it out on some people with an injury. I've tried this, I do IMEs, and I've tried this I do IMEs, people who are going through a common law claim, and I've done a sample of 50 on the common law claim, and I think it's a waste of time there because things are set in concrete. But it was the only way I was going to know whether I thought it would be valuable at that stage. So I'm coming back to that point, as there's a fair bit to become familiar with this. It's a bit to become familiar with the tool and the responses and then what you do with it. So just start simple and then build it up over time. Develop a network of people who might support you with it. A couple of things finishing off with before, hopefully there's some questions. I see there's some in there for answering, so that's great. Just finishing off quickly with It Pays to Care. If you haven't heard about us, if you Google It Pays to Care, you'll come across us. We've got our own dedicated website. So we started this, we launched the policy in April of 2022. There is two main reasons. Outcomes for people with comp claim are worse. So you hurt your shoulder, same severity, same type of problem, compensable situation, worse outcomes. Crazy. We spend all this money. We spend a huge lot of money on workers' comp, aiming to get better outcomes for people. So the fact we get worse outcomes, it's like, what are we doing? So that's one of the reasons we wrote It Pays to Care, massive project. And the second reason is the community we serve, the working or would-be working population. We know that when they stay out of work, it's bad for them, financial stressors, families break up, kids are distressed. So it's really important we get this right, we do better. And so this is our endeavour. We've been advocating since April 2022, and WorkSafe Tasmania has been very engaged from the board down, and we've done some work with the public sector in Tassie and doing more with the public sector. There's two main papers, an evidence-based paper. If you're interested in this area, I'd commend you to read it. Sounds like a lot, 180 pages, but it's a fairly easy read, and most people in the industry find it quite easy to read and useful, from CEOs to case managers. It brings all the evidence together across the role of the regulator and the policymaker to the case management, to the health, to workplace and the healthcare. And there's a values and principles-based paper. Explicitly, we call out values and principles. We're all a bit cynical about values. We see them go out the window when money comes into the fore. And so we're a bit cynical, but they really do matter. Fairness, trust, reciprocity, all of those things, open communication, transparency. If you don't get them right, life is so much harder. So it's not airy-fairy soft stuff. It's real, it's tangible, it makes a huge difference. There's resources here for you. These are a lot of, if you're interested, these are a lot of webinar recordings. In April of 2023, we brought people from around the country and did a symposium on this topic. And in preparation for it, because we wanted to be more discussion, we did a lot of knowledge-based information via video. So this is an interesting area to you. Please look at it. On the It Pays to Care website, we've also got a best practice guide if you're looking at this at a scheme level. And here are links to It Pays to Care, and also our LinkedIn profile, because our our comms specialist is great at producing infographics that can be useful for you. Okay, and back to the WorkSafe month slide for question time. So, Brendan, do you want to ask these out, or do you want me to?
Well, if you're happy to read them yourself, or I can throw to you, but
I'll read them. Cool. So, do you have any suggestions for getting a workplace on board with psychosocial hazards management? Huge stigma around it. So this is the prevention of psychosocial hazards regulations, I presume you're referring to, Wendy. It's a great question, probably not a huge amount of time to address it now. I think that it's really easy to get bogged down in the details of it. But if you think about the workplace, there's two kind of things going on. There's hazards, and then there's things that help, psychosocial support and psychosocial hazards. So we use the psychosocial safety climate. It's a research tool that measures the psychosocial climate. It's not just psychosocial health, it measures the safety leadership as well. And, what we can see is when there's a good psychosocial safety climate, return to work is 8 days versus a low social safety climate of 52 days. So the prevention of psychosocial hazards has a massive bearing on claims numbers and claims outcomes. So you want to think about that. So my brief answer to you is do it as an integrated team if you can. You want to do it with HR, return to work, and OH&S. You've got to do it as a team. You got to work together because that's where you connect the dots. I did a webinar connecting the dots last year with WorkSafe Tassie or 2023. So that might still be around. But you've got to work together. The second thing is you want to look at the supports and hazards. So there's lots of things that drag us down in the workplace, but there's lots of things that lift us up. We've known from the Vietnam War days that people with PTSD who weren't part of a team and a unit did badly. And, you don't remember the Vietnam War days, probably not a good analogy, but people came home from the Vietnam War and were disenfranchised because everyone was pissed off about the war. So the PTSD impacts were massive. And we can see that in current studies of workplaces. So we look at PTSD in emergency services, which is a huge issue. The impact is more related to the organisational culture than the actual clinical case of PTSD. So organisational culture, if you get that right, that can get better outcomes than the treatment results we get. So look at the balance between the two. Don't make it too complicated. There's lots of barriers in the workplaces, but there's also lots of support structures. You can drag the team down by just looking for problems. We are in a bit of a world at the moment where we focus on problems rather than solutions. It's a big fight in this little town I live with about where the new public toilet should go, A or B, and it's like divided the town. It's like focusing on the problems. So make sure at the workplace you're doing both. What are the links with perceived injustice and moral injury? So perceived injustice is a massive risk factor for prolonged work disability. You treat me badly. I think you've treated me badly. What am I going to do back? Reciprocity, you give me a $20 box of chocolates. I might give you a $30 bunch of flowers. That's the way reciprocity works at a research level. You treat me badly, I'm going to feel entirely justified in treating you badly back. So that's what perceived injustice is. You've done me wrong. I feel I have little compunction that I need to help you or be cooperative with you. So it just makes so much sense in people's lives. I haven't really thought about moral injury and how psychosocial screening and matched care could relate to moral injury. I get the whole moral injury issue. It is an issue. But I haven't got quite in my mind how I can link it to that at the moment. WorkSafe has. I've got lost with my answering my questions. I think I've done that. Another concern is when a PCBU disputes a workers' compensation claim as their right. Surely that can only add to the risks. Absolutely. So via Return to Work Matters, we've got some stuff for line managers or small business owners just on this, because, you know, they come to it with their own mindset, and particularly micro businesses. You know, we've seen it all. You can't just accept all claims. You'll have an avalanche of them. You know, the supervisor says, you know, the production manager says, oh, I'm sure that's related to his car accident 43 years ago. I literally have heard that. So it is just such a negative approach. Absolutely, there needs to be good decision making about claims. You know, if something's black and white, but then maybe, but you've got to realize questioning a claim puts you 5 steps back. You've got to be, we in this system I talked about 20 years ago, we probably asked for about 4 out of 2,000 claims to be questioned. And let me tell you, those ones are the ones that went off the rails. We only did it because the employer was really determined and the evidence they were giving us. But it is just such a losing starting point unless you are sure you are going to be effective. Kim asks, is a general person qualified to do this? The general person, I would say, is qualified to do the screening. I think the assessment, you want to be able to be very good or trained. I know in New South Wales with their system of work, they left it to the case manager to do the assessment, and they really struggled with it. So I do think you want to have skills and experience to do the assessment, and you definitely need the skills to do the counselling. What are the links with, I'm going backwards, my questions. When you refer to an independent medical consultation, do you mean the IME funded by the insurer, or do you mean a specialist that the GP refers to? Rebecca, thanks for asking. Sorry, I was just looking at the next comment about the links not working. In New South Wales, where the WISE study was done, they have this special person called an injury management or had this special thing called an injury management consultation. So the person who does that is typically an occupational physician, and it is partway between being a treating specialist and an IME. So they do an assessment, like you're told to come to this doctor, like an IME, and then the person focuses not on liability or, you know, but on the here and now issues of return to work and making sure the treatment's fine. And then they speak with the GP. So it's halfway in between. It's a special legislative role in New South Wales. Australia Post, because they're doing this nationally, what they did is they set up a case conference with the treating GP at 6 weeks. So they took a different model because they weren't going to find experienced doctors, and they weren't going to have the injury management consultations around Australia. So they said, okay, well, let's go with the GP. And because they've been so proactive and helpful with the person in the first few weeks, the GPs, and they set it up well, and they set it up in advance, and they booked a right time, then the GPs were engaged, and they had very few problems with GPs. I would say the same thing from our work 20 years ago. We were very much focused on maintaining the relationship between the worker and their workplace. And when you do that, and when the person wants to be back at work, the GP will typically follow suit. So I was surprised that the Australia Post system had such good results with the healthcare providers that way, but it makes sense when you think about it, because patients were on board. The GP will follow the patient much of the time. And so, yep, that's what I would say there. And Brendan, I think that's all of the questions. Oh, no, there's one. No.
Yep, Peter's just popped one up.
I've just seen one from Glenn earlier that I'd missed, and Glenn asked, what sort of percentage of psychosocial hazards result in hospitalisation? Glenn, I have no idea. It'd be great to know. I think secondary mental health. Yeah, it'd be great to know from ROI perspective. So secondary mental health, you reduce this significantly. And if you're going to reduce secondary mental ill health, you're going to lower the flow-on consequences of that. But could I quantify it? No, couldn't. We know from other surveys and other data that people with a comp claim are already more distressed than the general population. We can kind of get that. It's not an easy system to navigate at times. And so they're more likely to get secondary mental ill health. In Victoria, this is WorkSafe data, 80% of people with a claim at 3 years have a formal diagnosis of depression. That is like crazy. That is like, what does that say about what we're doing to people? Anyhow, we can minimize the problems, including hospitalisation if we get in early. Associate Professor Ross Isles has a really nifty way of talking about this. What he talks about is, if you are looking at a claim at 6 months or what's happened with an injury, blind Freddie could often go and say at 6 months, 9 months, that psychosocial factors are dominating here. But the trouble is, by that stage, it's set in concrete. And it's pretty hard to change it. Whereas if you get in early, and weeks matter in this situation. More questions? As an OEP, Peter asks, I'm doing injury management type work with TASPOL, seems to be well accepted. Are you doing it with TASPOL, Peter? I didn't know that you were doing psychosocial screening with them. Good on you. Lisa, is case conferencing still viable within the current primary care model? Our insurer has indicated a little shift in this space due to capacity preference of insurer to lead this by injury management. I, Lisa, fully don't understand exactly your question, but I think Australia Post has said it is viable, but their way of doing it is setting it up well. And if you've got the patient engaged, I don't know how viable it is without the patient engaged. It's certainly, you hear lots of great experiences from case conferences when people can do it well. We did do a webinar via RTW Matters with Ria Mercado about 6 months ago on medical case conferencing. If it's a struggle for you, please have a look at it. She's very experienced and a lot of valuable tips. So Lisa says, our insurer has indicated their preference to lead rather than employer-based injury management. I'll leave that to you, Lisa. I don't know the ins and outs of it, but could there be value in one of the things we all have to learn with AI, if we're learning AI, is what you delegate to AI. It's like, what do you do and what does it do? And I don't know if you saw that some big report released with lots of AI errors in it. That's like, you're not even worked out your delegation levels. I'm trying to use that as an analogy. It may not be a good one, but we've got to work out how we best work together. Who takes the lead? Who, does what? It's that collaborative approach, and sometimes some people are in a better position to do one thing and others are better positioned to do others. And Brendan's nodding his head, so that might be time to wrap up. Thanks, Lisa.
Yeah, thanks. That was well hashed out there at the end. Well, thank you, Mary. It's obvious you've got a tremendous passion, perhaps grown from your insights from research and practice into this very human issue, and it's great to have a human-centered approach that we can all share and learn more about. We'll follow up with some of the links that she mentioned, Dr. Mary Wyatt mentioned, for instance, the previous presentation from last year's WorkSafe around connecting the dots, and also the links to the Open Pain Network. There will be a survey for participants. Thank you all for coming along today. Once we end the slideshow, if you don't mind giving us your thoughts on the presentation, we'll use that for future. And a reminder to go to worksafe.tos.gov.au/month and see what else we've got on offer. Thanks again, Dr. Wyatt, for your time and wisdom and insight this afternoon. And thanks again to the presenters for coming along.
Thanks, everyone.
Enjoy the rest of the afternoon.